Association. It was the brainchild of so many doctors who have practiced in Bangalore, including late Mohandas Bhandari, late Dr. Kudwa, and Dr. Ashok Bhatt, and myself, and so many, Dr. Kumaraswamy, Kailash Chetty, all are, I think 80% of the seniors who are involved in the formation of Family Doctor Association is here today. We are going to witness few more, my friends. They are going to come from Kavuru, Kuluru, Adyar, Padil, going to join us. Thing is, when we started Family Doctor Association, ಇದು ಬೇಕಾ, ಫ್ಯಾಮಿಲಿ ಡಾಕ್ಟರ್ ಅಸೋಸಿಯೇಷನ್ ಬೇಕಾ ಎನ್ನುವಂಥ ಗೊಂದಲ ಇತ್ತು. ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಇದೆ, IAP ಇದೆ, ಮೆಡಿಸಿನ್ ಅಸೋಸಿಯೇಷನ್ ಇದೆ, ಸರ್ಜರಿ ಅಸೋಸಿಯೇಷನ್ ಇದೆ, ಆರ್ಥೋಪೆಡಿಕ್ಸ್ ಅಸೋಸಿಯೇಷನ್ ಇದೆ, ಕ್ಯಾನ್ಸರ್ ಅವ್ರದ್ದಿದೆ, OBG ಅವ್ರದ್ದಿದೆ. ಈ ಫ್ಯಾಮಿಲಿ ಡಾಕ್ಟರ್ ಅಸೋಸಿಯೇಷನ್ ಬೇಕಾ ಅಂತ ಒಂದು ಗೊಂದಲ 20 ವರ್ಷದ ಹಿಂದೆ ಇತ್ತು. ಆದರೆ ಈಗ ನಾವೆಲ್ಲರೂ ಹೇಳ್ತಾ ಇದ್ದೇವೆ, ಕುಟುಂಬ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿ ನಿರ್ಮೂಲನ ಆಗ್ತಿದೆ. ಅದು ಮುಗಿದೋದ್ರೆ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿಯ ಎಲ್ಲ ಬ್ರಾಂಚುಗಳು ಶಿಥಿಲ ಆಗ್ತವೆ ಅನ್ನೋ ಮಾತು ಕೇಳಿ ಬರ್ತಾ ಇದೆ. 20 ವರ್ಷದ ಹಿಂದೆ ನಾವು ಆರಂಭಿಸಿದ್ದು, ನಾವು 40 ಜನರ ಒಂದು ಗುಂಪಿನೊಂದಿಗೆ, 40-50 ಜನರ ಗುಂಪಿನೊಂದಿಗೆ ನಾವು ಮೂಡುಶೆಡ್ಡೆ ಹತ್ತಿರುವ ಪಿಲಿಕುಳದಲ್ಲಿ ಕಾಣ್ತಾರೆ ಅಲ್ಲ, ಕೈಲಾಶ್ ಶೆಟ್ಟರ್, ಪಿಲಿಕುಳದಲ್ಲಿ ಭಾರತೀಯ ಈ ಫ್ಯಾಮಿಲಿ ಡಾಕ್ಟರ್ ಅಸೋಸಿಯೇಷನ್ ಉದ್ಘಾಟನೆ ಮಾಡಿದ್ವಿ. ಅಂದಿನಿಂದ ಇಂದಿನವರೆಗೆ ಇಡೀ ಮಂಗಳೂರಿನಲ್ಲಿ ಯಾವುದೇ ಅಸೋಸಿಯೇಷನ್ ಮೀಟಿಂಗ್ ಆಗದೇ ಇದ್ದರೂ ಫ್ಯಾಮಿಲಿ ಡಾಕ್ಟರ್ ಅಸೋಸಿಯೇಷನ್ ಮೀಟಿಂಗು ಆಗ್ತಾನೆ ಇರ್ತದೆ. ಯಾವಾಗಲೂ ಪ್ರತಿ ತಿಂಗಳಲ್ಲಿ ಆಗ್ತಾ ಇರ್ತದೆ. ಅದು ಎಲ್ಲ ರೀತಿಯ ಸವಲತ್ತುಗಳಲ್ಲಿ ಸುಸಜ್ಜಿತವಾದ ಒಂದು ಮೀಟಿಂಗ್ ಆಗ್ತಾನೆ ಇರ್ತದೆ, ಇಲ್ಲ ಆಗದೇ ಇದ್ದರು. ಹಾಗಾಗಿ ಕೋವಿಡ್ ಸಮಯದಲ್ಲಿ ನಾವು ಸಾಕಷ್ಟು ಜನ ನಮ್ಮ ವೈದ್ಯರುಗಳನ್ನು ಕಳ್ಕೊಂಡ್ವಿ. ಫ್ಯಾಮಿಲಿ ಡಾಕ್ಟರ್ಸಲ್ಲಿ ಒಂದು 7-8 ಮೆಂಬರ್ಸ್ ಹ್ಯಾವ್ ಡೈಡ್. ಅದು ನಮಗೆ ಸ್ವಲ್ಪ ನೋವು ಕೊಟ್ಟಿದೆ. ಆದರೆ ಕುಟುಂಬ ವೈದ್ಯಕೀಯ ಸಂಘ ಅತ್ಯಂತ ಬಲಿಷ್ಠ. ರಾಜ್ಯದಲ್ಲಿ ಕೆಲವೇ ಕಡೆ ಕುಟುಂಬ ವೈದ್ಯರ ಸಂಘಟನೆ ಇದೆ. ಮಂಗಳೂರಲ್ಲಿದೆ, ಬೆಂಗಳೂರಲ್ಲಿದೆ, ಮೈಸೂರಲ್ಲಿದೆ, ಬಳ್ಳಾರಿಯಲ್ಲಿದೆ. ಆದರೆ ಮಂಗಳೂರಿನ ಕುಟುಂಬ ವೈದ್ಯ ಸಂಘಟನೆಗೆ ಒಂದು ಹೆಸರಿದೆ. ಯಾಕಂದರೆ ಲೀಡಿಂಗ್ ಪ್ರಾಕ್ಟೀಷನರ್ಸ್ ಫ್ಯಾಮಿಲಿ ಡಾಕ್ಟರ್ ಅಸೋಸಿಯೇಷನ್ ಅವರನ್ನು ಮಂಗಳೂರಿನಲ್ಲಿ 8 ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಇದ್ದರೂ ಸಹ ಆ ಎಲ್ಲ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ನವರು ನಮ್ಮ ಫ್ಯಾಮಿಲಿ ಡಾಕ್ಟರ್ ಅಸೋಸಿಯೇಷನ್ನ ಸೀನಿಯರ್ ಡಾಕ್ಟರ್ಸ್ಗಳಿಗೆ ರೆಸ್ಪೆಕ್ಟ್ಫುಲ್ ಆಗಿ ಅವ್ರು ನೋಡ್ಕೊಳ್ತಾರೆ. ಅವ್ರು ಹೇಳಿದ್ದಕ್ಕೆ ಅವ್ರ ಹತ್ರ ಡಿಸ್ಕಸ್ ಮಾಡ್ತಾರೆ, ಅವರ ಪೇಷಂಟ್ಗಳ ಬಗ್ಗೆ ಮಾತಾಡ್ತಾರೆ. ಈ ರೀತಿಯ ಗೌರವ ಇರುವುದನ್ನು ನಾನು ಬೇರೆ ನಗರಗಳಲ್ಲಿ ಕಂಡಿಲ್ಲ. ಹಾಗಾಗಿ ಕುಟುಂಬ ವೈದ್ಯದ ಹಿರಿಯ ವೈದ್ಯರುಗಳಿಗೆ ಈ ಕ್ರೆಡಿಟ್ ಸಲ್ತದೆ. ಆದರೆ ಈಗ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ನಾವೆಲ್ಲ ಓದುವಾಗ ನಾವು ಕಸ್ತೂರ್ಬಾ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ 1ರಲ್ಲಿದ್ವಿ. ವೆನ್ಲಾಕ್ ಹಾಸ್ಪಿಟ್ಲು, ಲೇಡಿ ಗೋಶನ್ ಹಾಸ್ಪಿಟಲ್, ಕಸ್ತೂರ್ಬಾ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್. ನಮ್ಮ ಕಾಲು ಹಾಕುವಷ್ಟು ಜಾಗ ಇಲ್ಲದಿದ್ದಷ್ಟು ಪೇಷಂಟ್ಗಳನ್ನು ನಾವು ವೆನ್ಲಾಕಲ್ಲಿ, ಲೇಡಿ ಗೋಶನಲ್ಲಿ ನೋಡ್ತಾ ಇದ್ವಿ. ಇಡೀ 8 ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿರುವ ಪ್ರೊಫೆಸರ್ಸ್ಗಳು ನಮಗೆಲ್ಲ ಟೀಚರ್ಸ್ ಆಗಿದ್ದರು. ಈಗೆಲ್ಲ ಹರಿದು ಹುಂಚಿ ಹೋಗಿದ್ದಾವೆ. ನಮ್ಗೆ ಆವಾಗ ಸೆಕೆಂಡ್ ಇಯರಿಗೆ ಬರುವಾಗಲೇ ನಾವು ಕುದಿತಾ ಇದ್ವಿ, ಪೇಷಂಟ್ ನೋಡಬೇಕು, ಟ್ರೀಟ್ ಮಾಡಬೇಕು ಅಂತ. ಈಗ ಸೆಕೆಂಡ್ ಇಯರ್ ಮಾಸ್ಟರ್ ಡಿಗ್ರಿ ಇದ್ದು ವಿದ್ಯಾರ್ಥಿಗಳಿಗೂ ಆ ರೀತಿಯ ಒಂದು ಕಾನ್ಫಿಡೆನ್ಸ್ ಇಲ್ಲ. ಹಾಗಾಗಿ MBBS ಮಾಡಿದವರನ್ನು ನಾವು ಏನಕ್ಕೂ ಬಾರದಿದ್ದವರು ಅಂತ ಮಾಡಿಬಿಟ್ಟಿದ್ವಿ. ಅದು ನಾವು ಮಾತ್ರ ಅಲ್ಲ, ನಾಗರಿಕರು ಸೇರಿ, ಜನರು ಸೇರಿ MBBS ಈಸ್ ನಥಿಂಗ್, ಅದೇನು ಅಲ್ಲ ಅಂತ. ಅದೇ ಆಯುರ್ವೇದ, ಹೋಮಿಯೋಪತಿ ಮಾಡಿದವರನ್ನು ನಾವು ಅವರನ್ನು ದೊಡ್ಡದ ಮಟ್ಟದಲ್ಲಿ ನೋಡ್ತೇವೆ. MBBS ಮಾಡಿದ ಆಯದಾಲ MBBS ಅತ್ತೆ ಅಂತ. ಬಟ್ MBBS ಅಲ್ಲಿ 38 ಸಬ್ಜೆಕ್ಟ್ಗಳನ್ನು ಓದಿ ಹೊರಗೆ ಬಂದಾಗ ಅವನಲ್ಲಿ ತುಡಿಯುವ ಉತ್ಸಾಹವನ್ನು ನಾವೆಲ್ಲ ಓದುವಾಗ ಇತ್ತು. ಈಗಿನ ವಿದ್ಯಾರ್ಥಿಗಳಿಲ್ಲ. ಯಾಕಂದರೆ ನಾವು ಅವರನ್ನು ಅವರ ಬೆಲೂನಿಗೆ ಸೂಜಿ ಚುಚ್ಚಿ ಟುಸ್ ಮಾಡಿಬಿಟ್ಟಿದ್ದೇವೆ. ಮಾಸ್ಟರ್ ಡಿಗ್ರಿ, ಸೂಪರ್ ಸ್ಪೆಷಲೈಸೇಷನ್ ಆದರೆ ಮಾತ್ರ ಕುಟುಂಬ ವೈದ್ಯ ಪದ್ಧತಿ ಉಳಿತದೆ ಅನ್ನೋ ಭಾವನೆ ಇದೆ. ಹಾಗಾಗಿ ಕುಟುಂಬ ವೈದ್ಯ ಅಸೋಸಿಯೇಷನ್ನ 2ನೇ ಅವಧಿ ಅಧ್ಯಕ್ಷ ಆಗಿದ್ದೇನೆ. ನಾನು ಸ್ಟಾರ್ಟ್ ಆದಾಗ ನಾನು ಸೆಕ್ರೆಟರಿ ಆಗಿದ್ದೆ. ಅನಂತರ 3 ವರ್ಷ ಬಿಟ್ಟು ಅಧ್ಯಕ್ಷ ಆದೆ. ಮೋಹನ್ದಾಸ್ ಭಂಡಾರವರಿಗೆ 2 ವರ್ಷ ಸೆಕ್ರೆಟರಿ ಆಗಿದ್ದೆ. ಕುಡುವವರಿಗೆ 2 ವರ್ಷ ಸೆಕ್ರೆಟರಿ ಆಗಿದ್ದೆ. ಈಗ ಮತ್ತೆ ಪುನಃ ಅಧ್ಯಕ್ಷ ಆಗಿ ಈಗ 2ನೇ ಬಾರಿ ಅಧ್ಯಕ್ಷ ಆಗ್ತಿದ್ದೇನೆ. ಅದರ ಜೊತೆಗೆ ರಾಜ್ಯ ಮಟ್ಟದಲ್ಲಿ ಕುಟುಂಬ ವೈದ್ಯರ ಸಂಘಟನೆಗೆ 2ನೇ ಬಾರಿ ಅಧ್ಯಕ್ಷರಾಗಿ ಆಯ್ಕೆ ಆಗ್ತಿದ್ದೇನೆ. ಏನಾದರೂ ಕುಟುಂಬ ವೈದ್ಯ ಪದ್ಧತಿಗೆ ಮಾಡಬೇಕು ಅನ್ನೋದೊಂದು. ಒಮ್ಮೆ ನಾವೆಲ್ಲ ಸೇರಿ ಶ್ರೀನಿವಾಸ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ನಲ್ಲಿ ಕುಟುಂಬ ವೈದ್ಯರ ರಾಜ್ಯ ಸಮ್ಮೇಳನ ಮಾಡಿದ್ವಿ. ಈ ಬಾರಿ ಕುಟುಂಬ ವೈದ್ಯರ ರಾಷ್ಟ್ರ ಸಮ್ಮೇಳನ ಮಾಡಲಿಕ್ಕೂ ಜವಾಬ್ದಾರಿಯನ್ನು ನಮಗೆ ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ನನಗೆ ತುಂಬ ಖುಷಿಯಾಗುತ್ತೆ. ನಾನು ಎಲ್ಲ ಸಾಕಷ್ಟು ಸಂಘಟನೆಗಳು ದುಡಿದಿದ್ದೇನೆ. ಅಲ್ಲಿ ಎಲ್ಲಿಯೂ ನಾನು ಅಧ್ಯಕ್ಷ ಆಗಲಿಲ್ಲ. ಅದು 2 ಬಾರಿ ಅಧ್ಯಕ್ಷ ಯಾವ ಸಂಘಟನೆಯಲ್ಲಿಯೂ ಆಗಿಲ್ಲ, ಇನ್ಕ್ಲೂಡಿಂಗ್ ಎಲ್ಲಿಯೂ ಆಗಿಲ್ಲ. ಆದರೆ FDAಯಲ್ಲಿ ನೀವು ನನ್ನ ಇಷ್ಟು ಚಿಕ್ಕ ಪ್ರಾಯದವನನ್ನು 2 ಬಾರಿ ಅಧ್ಯಕ್ಷ ಆಗಿ ಮಾಡಿದ್ರಿ 20 ವರ್ಷದಲ್ಲಿ. ಅದಲ್ಲದೆ ರಾಜ್ಯ ಅಧ್ಯಕ್ಷ ಆಗುವ ಒಂದು ಜವಾಬ್ದಾರಿಯನ್ನು ನಿಮ್ಮೆಲ್ಲರ ಪ್ರೀತಿಯಿಂದ ಸಿಕ್ಕಿದೆ. ಇದೆಲ್ಲ ಕ್ರೆಡಿಟ್ಟು ಮಂಗಳೂರಿನ ಕುಟುಂಬ ವೈದ್ಯರಿಗೆ ಸಲ್ಲಲೇಬೇಕು. ನಾನು ನಿಮಗೆ ಆಭಾರಿಯಾಗಿದ್ದೇನೆ, ಯಾಕಂದರೆ ನನ್ನ ಮೇಲೆ ನಂಬಿಕೆ ಇಟ್ಟು ನನ್ನನ್ನು ಬೆಳೆಸಿದ್ದಕ್ಕೆ. ನೀವೆಲ್ಲ ನನ್ನ ತಂದೆ ಪ್ರಾಯದವರೆಲ್ಲ ಇಲ್ಲಿದ್ದಾರೆ, ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡೋರಿದ್ದೀರಿ. ಹಾಗಾಗಿ ನನಗೆ ಮನ ತುಂಬಿ ಬಂದಿದೆ. ರಾಜ್ಯದವರು ನನಗೆ ಆ ಜವಾಬ್ದಾರಿ ಕೊಟ್ಟಿದ್ದಾರೆ, ರಾಜ್ಯದ ಅನಾನಿಮಸ್ ಆಗಿ ಸೆಲೆಕ್ಟ್ ಮಾಡಿದ್ದಾರೆ. ಅದಲ್ಲದೆ ಕುಟುಂಬ ವೈದ್ಯ ಪದ್ಧತಿಯಲ್ಲಿ ನಾವು ಒಂದು ಕೆಲಸ ಮಾಡಿದ್ದೇವೆ. ಕಾಯಿಲೆಗಳು ಮನೆ ಮಾತು, ವೈದ್ಯರ ಕಿವಿ ಮಾತು ಅಂತ ಒಂದು ಪುಸ್ತಕವನ್ನು 10 ವರ್ಷದ ಹಿಂದೆ ನಾವು ಬರೆದಿದ್ವಿ. ಮ್ಯಾಂಗ್ಳೂರಿನ ಲೀಡಿಂಗ್ ಡಾಕ್ಟರ್ಸ್ ಇಂಗ್ಲೀಷ್ ಬರೆದದನ್ನು ಕನ್ನಡಕ್ಕೆ ಟ್ರಾನ್ಸ್ಲೇಟ್ ಮಾಡಿ ಆ ಪುಸ್ತಕವನ್ನು ನನ್ನ ಸಂಪಾದಕತ್ವದಲ್ಲಿ ನಾವು ಬಿಡುಗಡೆ ಮಾಡಿದ್ವಿ. 2012ರಲ್ಲಿ ಆಗಿದ್ದು, 2022ರಲ್ಲಿ ಅದನ್ನು ತುಳುಕ್ಕೆ ಟ್ರಾನ್ಸ್ಲೇಟ್ ಆಗಿದೆ. ನಾವು 3000 ಪುಸ್ತಕವನ್ನು ಅದನ್ನು ಡಿಸ್ಟ್ರಿಬ್ಯೂಟ್ ಮಾಡಿದ್ದೆ ಆವಾಗ. ಅದರ ಸಾಫ್ಟ್ ಕಾಪಿ ಎಷ್ಟೋ ವೈರಲ್ ಆಗಿದೆ. ಸಾಹಿತ್ಯ ಅಕಾಡೆಮಿಯವರು ಆ ಪುಸ್ತಕವನ್ನು ಮೊನ್ನೆ ಬಿಡುಗಡೆ ಮಾಡಿ ಗಡಿಬಿಡಿಯಲ್ಲಿ ಬಿಡುಗಡೆ ಮಾಡಿದರು. ಆದರೆ ಅದನ್ನು ಲೋಕಾರ್ಪಣೆ ಸರಿಯಾಗಿ ಆಗಲಿಲ್ಲ, ಜನರಿಗೆ ಮುಟ್ಟಲಿಲ್ಲ. ಅವತ್ತು ಪುಸ್ತಕವೇ ಬಂದಿರಲಿಲ್ಲ ಅಲ್ಲಿ. ಈಗ ಒಂದು 2000 ಪುಸ್ತಕ ತುಳು ಸಾಹಿತ್ಯ ಅಕಾಡೆಮಿ ಬಂದಿದೆ. ಅದನ್ನು ನಾವು ಅಫಿಷಿಯಲ್ ಆಗಿ ಮೂಡುಬಿದಿರೆಯ ರಾಜ್ಯ ವೈದ್ಯ ಸಮ್ಮೇಳನದಲ್ಲಿ ಬಿಡುಗಡೆ ಮಾಡಿದ್ವಿ. ಅಲ್ಲಿಯೂ ನಮಗೆ ಕಾಪಿ ಇರಲಿಲ್ಲ, ನಾವು ಜೆರಾಕ್ಸ್ ಕಾಪಿಯನ್ನು ಪ್ರತಿಬಿಂಬಡಿ ಮಾಡಿದ್ದು. ಇವತ್ತು ನಮ್ಗೆ ಕಾಪಿ ಸಿಕ್ಕಿದೆ, ಇವತ್ತು ಬಿಡುಗಡೆ ಆಗ್ತದೆ. ಮತ್ತು IMAಯಲ್ಲಿಯೂ ಬಿಡುಗಡೆ ಆಗ್ತದೆ. 100 ರೂಪಾಯಿಗೆ ಆ ಪುಸ್ತಕ ಸಿಗ್ತದೆ, ತುಳು ಸಾಹಿತ್ಯ ಅಕಾಡೆಮಿಯಲ್ಲಿದೆ. ನಿಮ್ಮೆಲ್ಲ ರೋಗಿಗಳಿಗೆ ನೀವು ಅಲ್ಲಿ ಹೇಳ್ಬೋದು. ಯಾಕಂದರೆ ನಾವು ಚಕ್ರಪಾಣಿ, ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿ, ಲೀಡಿಂಗ್ ಲಿಜೆಂಡರಿ ಡಾಕ್ಟರ್ಸ್ ಆಫ್ ದ ಮ್ಯಾಂಗ್ಳೂರ್, 30 ಜನ ಲಿಜೆಂಡರಿ ಡಾಕ್ಟರ್ಸ್ಗಳು ಈ ಕನ್ನಡದಲ್ಲಿ ಬರೆದದ್ದು, ಇಂಗ್ಲೀಷಲ್ಲಿ ಬರೆದದನ್ನು ಕನ್ನಡಕ್ಕೆ, ಕನ್ನಡದಲ್ಲಿ ಬರೆದದನ್ನು ತುಳುಗೆ ಟ್ರಾನ್ಸ್ಲೇಟ್ ಮಾಡಿದ್ದೇವೆ. ಇದು ಹಿಸ್ಟ್ರಿಯಲ್ಲಿ ಆಗಲಿಲ್ಲ, ಮಂಗಳೂರಿನ ಹಿಸ್ಟ್ರಿಯಲ್ಲಿ ಇದಾಗಿಲ್ಲ. ಇದಕ್ಕೆ ಕಾರಣ ಕುಟುಂಬ ವೈದ್ಯರ ಸಂಘಟನೆ ಮತ್ತು ರಾಜ್ಯ IMA ಮತ್ತು ಮಂಗಳೂರು IMA, ಇದನ್ನು ಸಹ ಇವತ್ತು ಬಿಡುಗಡೆ ಆಗಲಿಕ್ಕಿದೆ. ಹಾಗಾಗಿ ಕುಟುಂಬ ವೈದ್ಯ ಪದ್ಧತಿ ನಶಿಸಬಾರ್ದು, ಅದನ್ನು ಉಳಿಸಿ ಬೆಳೆಸುವ ಜವಾಬ್ದಾರಿ ನಮ್ಮ ಮೇಲಿದೆ, ಮೆಡಿಕಲ್ ಕಾಲೇಜುಗಳ ಮೇಲಿದೆ, ಶಿಕ್ಷಕರ ಮೇಲಿದೆ. ಈಗ ಟೀಚಿಂಗ್ ಕಾನ್ಸೆಪ್ಟು ಸಹ ವೀಕ್ ಆಗ್ತಾ ಇದೆ. ಮಕ್ಕಳಿಗೆ ಟೀಚಿಂಗ್ ಬಗ್ಗೆ ಆಸಕ್ತಿ ಉಳಿದಿಲ್ಲ. ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಕಳಿಸಿದ್ರು ಸ್ಪೂನ್ ಫೀಡಿಂಗ್ ಆಗ್ತಾಯಿದೆ. ಆಫ್ಲೈನ್ ಆನ್ಲೈನ್ ಎಕ್ಸಾಮ್ ಇದು ಟೀಚಿಂಗ್ ಬಂದ ಮೇಲೆ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಇದು ಬೇಕೋ ಬೇಡೋ ಅನ್ನೋ ಸ್ಥಿತಿ ಮುಟ್ಟಿದೆ. ಹಾಗಾಗಿ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಎನ್ನುವುದು ಈಗ ಕವಲು ದಾರಿಯಲ್ಲಿ ನಿಂತಿದೆ ಅಲ್ವಾ. ಇಟ್ಸ್ ಬ್ರ್ಯಾಂಚ್, ಇದು ಜಂಕ್ಷನಲ್ಲಿದೆ. ಈಗ ಏನು ಮಾಡಬೇಕು ಏನು ಮಾಡಬಾರ್ದು ಅನ್ನೋ ಚಿಂತನೆ ಇರುವ ಕಾಲಘಟ್ಟದಲ್ಲಿ ಮಂಗಳೂರಿನ ಕುಟುಂಬ ವೈದ್ಯ ಸಂಘಕ್ಕೆ ದೊಡ್ಡ ಜವಾಬ್ದಾರಿ ಇದೆ. ನಾವು ಹೆಗಲುಕಟ್ಟು ಬೆಳೆಸಿದ ಈ ಸಂಸ್ಥೆಯನ್ನು ಇನ್ನಷ್ಟು ಜನರ ಹತ್ತಿರ ಹೋಗಬೇಕಾಗಿದೆ. MBBS ಅಂದರೆ ದೇ ನೋ ಎವ್ರಿಥಿಂಗ್. ಮೊನ್ನೆ ಡಾಕ್ಟರ್ CR ಬಲ್ಲಾಳ್ ಸರ್ ಹತ್ರ ನಾನು ಆನ್ಲೈನ್ ಇಂಟರ್ವ್ಯೂ ಮಾಡ್ತಿದ್ದೆ. ಅವರ ಕ್ಲಾಸ್ ಅಂದರೆ ಇಡೀ ಮಂಗಳೂರಿನಲ್ಲಿ ಎಲ್ಲ ಸ್ಟೂಡೆಂಟ್ಸ್ಗಳು ವೆನ್ಲಾಕ್ ವಾರ್ಡಿಗೆ ಬರ್ತಿದ್ರು. ಅವ್ರು ಹೇಳ್ತಿದ್ದಾರೆ, ಈಗ ಕುಟುಂಬ ವೈದ್ಯತೆ ಪದ್ಧತಿ ಹೋದರೆ ಎಲ್ಲ ಹಾಳಾಗಿ ಹೋಗುತ್ತೆ. ಅದೇ ಮೇನ್ ಕೊಂಡಿ, ಕುಟುಂಬ ವೈದ್ಯ ಪದ್ಧತಿ ಅನ್ನೋದೇ ಕೊಂಡಿ. ಆ ಕೊಂಡಿ ಉಳಿಬೇಕಾದ್ರೆ ನೀವೆಲ್ಲ ತೊಡಗಿಸಬೇಕು. ಮತ್ತು MBBS ಅಂದರೆ ಏನೂ ಅಲ್ಲ ಎನ್ನುವುದನ್ನು ಜನರು ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಬೇಕು, ಕನ್ಸಲ್ಟೆಂಟ್ಗಳು ಹೇಳಬೇಕು, ಸೂಪರ್ ಸ್ಪೆಷಲಿಸ್ಟ್ಗಳು ಹೇಳಬೇಕು. ಜನರಲ್ ಪ್ರಾಕ್ಟೀಷನರ್ ಮಾತ್ರ ಸಮಾಜಕ್ಕೆ ಸರಿಯಾದ ಸಂದೇಶವನ್ನು ಕೊಡಬೇಕಾದವರು, ಮಾರ್ಗದರ್ಶನ ಕೊಡಬೇಕಾದವರು. ಅದಕ್ಕಾಗಿ ಇವತ್ತಿನ ಟಾಪಿಕ್ಕು ರೋಲ್ ಆಫ್ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಷನರ್ ಇನ್ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್. ಡಾಕ್ಟರ್ ಪ್ರಶಾಂತ್ ಇಸ್ ಅ ವಂಡರ್ಫುಲ್ ಪರ್ಸನ್. ಕ್ಯಾನ್ಸರ್ ಬಗ್ಗೆ ಅರ್ಬುದಾಸುರ ವಧೆ ಅನ್ನೋ ಒಂದು ಯಕ್ಷಗಾನವನ್ನು ನಾವು ಮಾಡಿ ಅದಕ್ಕೆಲ್ಲ ಸ್ಪಾನ್ಸರ್, ನಾವೆಲ್ಲ ವೇಷ ಮಾಡಬೇಕಾದ್ರೆ ಅದಕ್ಕೆ ಬಣ್ಣ ತೊಡುಗೆಲ್ಲ ಹಾಕಬೇಕಾದ್ರೆ ಸ್ಪಾನ್ಸರ್ ಮಾಡಿಕೊಟ್ಟವರು ಪ್ರಶಾಂತ್ ಹತ್ರ ಹೇಳಿದ ತಕ್ಷಣ ಹೀಗೆ ಮಾಡಬೇಕು, ಎಸ್ ವಿ ವಿಲ್ ಡೂ ಇಟ್. ಜನರಿಗೆ ಅವೇರ್ನೆಸ್ ಕೊಡುವ ಕೆಲಸ ಮಾಡುವಂಥ. ಯಾಕಂದರೆ ಪ್ರಶಾಂತ್ ಮತ್ತು ನಮ್ಮ IG ಭಟ್ರ ಮಗ ಡಾಕ್ಟರ್ ಕೃಷ್ಣ ಪ್ರಸಾದ್ ಮತ್ತು ರೋಹನ್ ಗಟ್ಟಿ ಮತ್ತು ನಾವು 4 ಜನ ಕ್ಯಾನ್ಸರ್ ಹೋರಾಟದಲ್ಲಿ ಯಾರಿಗೂ ಗೊತ್ತಿಲ್ಲ, ಒಟ್ಟೊಟ್ಟಿಗೆ ಕೆಲಸ ಮಾಡ್ತಾಯಿರ್ತೇವೆ. ಪ್ರಶಾಂತ್ ಹೆಮಟಾಲಜಿಸ್ಟ್, ಬ್ಲಡ್ಡಲ್ಲಿ ಏನು ಕ್ಯಾನ್ಸರ್ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ತದೆ ಅಂತ ಹೇಳಿದರೆ ಮೆಡಿಸಿನ್ ವಿಭಾಗದಲ್ಲಿ ನಮ್ಮ ಕೃಷ್ಣ ಪ್ರಸಾದ್, ಸರ್ಜರಿಯಲ್ಲಿ ಗಟ್ಟಿ. ಮತ್ತು ನಾವೆಲ್ಲ ಸೇರಿಕೊಂಡು ಹೇಗೆ ಹಣ ಒಟ್ಟು ಮಾಡಿ ಸೇರಿಸಿ ಕೊಡ್ಬೋದು, ರೋಗಿಯನ್ನು ಬದುಕಿಸ್ಬೋದು ಅನ್ನೋದು ನಾವು 3-4 ಜನ ಸೇರಿಕೊಂಡು ಇವರನ್ನು ಕಾಲಿಡಿದು ಪೇಷಂಟ್ಗಳನ್ನು ಉಳಿಸುವ ಕೆಲಸ ನಾವು ಮಾಡ್ತಾಯಿದ್ವಿ. ಇದು ಎಷ್ಟು ಜನರಿಗೆ ಗೊತ್ತಿಲ್ಲ. ನಾವು 4 ಜನ ಒಂದು ಗ್ರೂಪ್ ಮಾಡ್ಕೊಂಡು ಕೆಲಸ ಮಾಡ್ತಿದ್ವಿ. ಹಾಗಾಗಿ ಇವತ್ತು ಕ್ಯಾನ್ಸರ್ ಬಗ್ಗೆ ಮಾತಾಡುವಂತ ಕೇಳಿಕೊಂಡಾಗ ಅವರು ಪ್ರೀತಿಯಿಂದ ಒಪ್ಕೊಂಡ್ರು. ನನಗೆ ಗೊತ್ತಿದ್ದಾಗ FDA ಮೀಟಿಂಗ್ನಲ್ಲಿ 9-9:30 ಆಗದೆ ಇಷ್ಟು ಜನ ಬರೋದೇ ಇಲ್ಲ. ಈಗ 8:00 ನೀವು ಇಷ್ಟು ಜನ ಬಂದಿದ್ದೀರಿ ಅಂದರೆ ಪ್ರಶಾಂತ್ ನಿಮ್ಮ ಬಗ್ಗೆ ಪ್ರೀತಿ ಮತ್ತು ನಿಮ್ಮ ಆಳ, ಯಾಕೆಂದರೆ ಅವರು 2-3 ಗಂಟೆ ಮಾತಾಡಬಲ್ಲರು ಕ್ಯಾನ್ಸರ್ ಬಗ್ಗೆ. ಅಂಥವ್ರ ಬಗ್ಗೆ ಪ್ರೀತಿ ಇಟ್ಕೊಂಡು ನೀವೆಲ್ಲ ಬಂದಿದ್ದೀರಿ. ಪ್ರಶಾಂತ್ ಅವರು ನಮ್ಮ ಕಳಕಳಿಗೆ ಒಪ್ಕೊಂಡು ಬಂದಿದ್ದಾರೆ. ಮತ್ತು ನಮ್ಮ ಇಂಟಾಸ್ ಫಾರ್ಮದ ಫ್ರೆಂಡ್ಸ್, ನಾನು ಕೇಳ್ಕೊಂಡಾಗ ಡಾಕ್ಟರ್ ಏನಾಗಬೇಕು ಹೇಳಿ ಮಾಡುವ ಕ್ಯಾನ್ಸರ್ ಬಗ್ಗೆ ಏನು ಡಾಕ್ಟರ್ಗಳಿಗೆ ಅವೇರ್ನೆಸ್, ಕುಟುಂಬ ವೈದ್ಯ ಪದ್ಧತಿ ಉಳಿಸುವಾಗ ಏನಾಗಬೇಕು ಮಾಡುವ ಅನ್ನೋ ಒಂದು ಕಾನ್ಸೆಪ್ಟ್ ಮಾಡಿದ್ರಿ. ಈ ಹೊಸ ವರ್ಷ, ಹಳೆ ವರ್ಷ ಮುಗಿದು ವರ್ಷದಲ್ಲಿ ನಾವು ಕುಟುಂಬ ವೈದ್ಯ ಪದ್ಧತಿಯನ್ನು ಉಳಿಸುವ ಬಗ್ಗೆ, ಅದನ್ನು ಬೆಳೆಸುವ ಬಗ್ಗೆ ನಾವು ಪಣ ತೊಡಲೇಬೇಕಾಗಿದೆ. ಸಾಕಷ್ಟು ಜನ ವೈದ್ಯರು ಬಂದಿದ್ದಾರೆ. ರಾಜೇಶ್, ನಮ್ಮ ವೆಲ್ನಾಕಿನ್ ಡಾಕ್ಟರ್ ಹೇಮಾ, ರಾಜೇಶ್, ಫ್ರೆಂಡ್ಸ್, ENT ಡಿಪಾರ್ಟ್ಮೆಂಟ್, ದೇರ್ ಆರ್ ಮೈ ಕ್ಲಾಸ್ಮೇಟ್ಸ್, ರಾಜೇಶ್ ಶೆಟ್ಟಿ, ಸೋ ಮೆನಿ ಹ್ಯಾವ್ ಕಮ್. ಸೊ ನಮ್ಗೆ ಖುಷಿ ಆಗ್ತದೆ. ಇನ್ನೂ ಒಂದು 25-30 ಜನ ಡಾಕ್ಟರ್ ನಮ್ಮ ಸೇರ್ಕೊಳ್ಳಿಕ್ಕಿದ್ದಾರೆ. ಅವರೆಲ್ಲ ಬ್ಯುಸಿ ಪ್ರಾಕ್ಟಿಷನರ್ಸ್. ಪೇಷಂಟನ್ನು ಬಿಟ್ಟು ಬಾಗಿಲಾಕ್ಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ. ಸೀನಿಯರ್ ಕನ್ಸಲ್ಟೆಂಟ್ ಪ್ರಾಕ್ಟಿಷನರ್ಸ್. ನಿಮ್ಮೆಲ್ಲರ ನಿರೀಕ್ಷೆಯಲ್ಲಿ ನಾವು ಕಾರ್ಯಕ್ರಮದ ಮುಂದೆ ಹೋಗ್ತಿದ್ದೇವೆ. ಇಲ್ಲಿ ನಿಂತು ನಿಮ್ಮ ಜೊತೆ 4 ಮಾತಾಡಲಿಕ್ಕೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟ ನಿಮಗೆಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ ಮಾಡ್ತಾ ನಾನು ಮಾತನ್ನು ಮುಗಿಸ್ತೇನೆ. ವಂದನೆಗಳು.
To the next portion, before going to the CME, Dr. Annaikular already told about the release of the book. So now releasing the book ceremony will be done now. So the Tulu Academy has released a book which was already printed in Kannada some time back about family physicians and illness of the patients, which was printed in 2012 in Kannada, was a good achievement that time. Now the Tulu Academy has come out with the Tulu version of the same book in 2022 after 10 years. Now today we are very proud to release the book in your audience guidance. So I request our today's Chief Guest Dr. Prashant B and our President Dr. Annaikular to release the book.
Rajesh,
Dr. Kumaraswamy, Dr. Rajesh. Yeah.
Please come.
Yeah. We got a dynamic president, Dr. Annaikular. As you all know, he has been selected lately as the director of IMA CGP College of General Practice. It is a very good position in the IMA's section, and also he has been selected as the IMA KSS Managing Committee President. Managing Committee performer. Managing Committee member. So I would like to felicitate him in front of your audience on behalf of all of us. Okay, please come out. A brief introduction of our today's chief guest, Dr. Prashant B. Dear friends, our today's chief guest, Dr. Prashant B, is a very well-known hematologist at KMC Mangalore. He did his MBBS from JSS Medical College, Mysore in the year 2003. Then he did his DNB in Medicine from Narayan Hridayalaya, Bangalore in 2009. Later he did his fellowship in hematology from Mazumdar Shaw Cancer Center, Narayana Health City, Bangalore in 2012. He started the first ever dedicated hematology center in Mangalore in 2012 at KMC Mangalore. Now he is heading the adult hematology department at KMC as Associate Professor of Medicine and Consultant Hematologist. His areas of interest are hematological disorders of elderly, acute leukemia, myelodysplastic syndromes, and myeloproliferative disorders, etc. Articles to his credit. He conducts social-oriented health education programs regularly. He has been conducting yearly CMEs for the benefit of fellow colleague doctors. I welcome Dr. Prashant B. I request
projector. First of all, I would like to thank Dr. Annaikular and Vivekanand sir for giving me an opportunity to come and address you people. Thank the Intas company because always, including I think our Prime Minister also told once, our doctors are getting freebies from pharmaceutical companies and, doctors are getting benefited, blah, 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 blah. But then It is the MNCs who always insist that, when we do a CME program, it has to be according to their whims and fancies. Indian companies, I would tell you, they don't bother what you talk. Live example, this Intas people, I told them we will do one program for FDA, Mangalore. So they told, okay, sir. They did not ask me what cancer you are talking, what drugs you are talking, sir, which drug of ours is you are talking. In my entire talk, they don't have any drugs, I don't mention any of their drugs. There is no pharmaceutical interest, and it has nothing to do with them. But still they are happy to sponsor this kind of event. This is the actual philanthropy of Indian pharmaceutical industry, So I really appreciate them. So with that, so now my venture here is not to give you big gyan on cancer. My job here is how we can work together. And what is a family doctor? When Dr. Annaya Kulal has been selected, rightfully as a president of, College of General Practitioners of an IMA, what is a family doctor? Lot of the people think that, there is a doctor in the family, so he is the family doctor. So we should know what exactly we are dealing with. So my role is how we can liaise in best interest of the patient and give best of the patient care in our society. So what is this family medicine? The family medicine is an accumulated body of knowledge dealing with the health, the state of total well-being of an individual within the family unit. That is a family medicine. And family practice is a specialty that provides continuous and comprehensive health care, without limitation by age, sex, organ system, or disease entity in relation to the family unit. Like age, there are geriatricians, there are pediatricians, specialists. We tell that, I am adult hematologist, I don't see children. Sex, gynecologists are not going to see gents. There is no business for them to see gents. Organ system, cardiologist doesn't see lung, doesn't see stomach. What is there. So, or disease entity, infectious disease specialists, they don't see other things like diabetes, hypertension. I am a hematologist, I see only hematology, I don't see anything else. So we are all short-sighted, small-sighted people. Our area of interest is restricted. In a small area, we know a lot of things. But you ask me today, I'll tell you, if I get an ECG of my patient, and I think that there is some doubt, I immediately WhatsApp it to Manish Rai. Dr. Manish Rai is the cardiologist. Because I don't know how to read ECG. Mine is, you give me CVC, I will tell you what is the disease. But you give me ECG, I will be stumped. Whereas you are not like that. You don't discriminate with all these things. I'm not telling that, you know everything. But then you are kind of, a master who can, at least make the initial diagnosis, initial therapy, to any patient. Whether a child comes, whether it is an adult, whether it's a lady, whether it's a gents, whether it's a heart problem, whether it's a lung problem. Yes, the initial treatment and that makes you a wholesome doctor, unlike us who are subspecialty doctors. And family doctor is the practitioner who implements the principles of the discipline of family medicine in the specialty of family practice. So person who gives this kind of a comprehensive care is the one who is a family doctor. So I am the doctor in my family, but I am not the family doctor for my family. Because I know only about hematology, I don't know about others. So if my own child gets sick, I have to take her to somebody else. So we know what is family doctor. Now he is a counselor, he is a coordinator, he is an advocate, he is a humanitarian. He works for the welfare of the society. In the selected areas of competence, the family physician is the physician best qualified to evaluate and manage the healthcare problems of the individual in the context of a family. You also know the patient who has come to you. You know the family background. You know how well they are, how much they can afford treatment, how much close-knit they are as a family. There may be familial disputes. Brothers and brothers may be having disputes. You know those things. As an end specialist sitting inside our chambers, we will not know anything except for the patient who has particular disease. So, as I told you, now family doctor is a licensed medical graduate, not an Ayurvedic physician, not a homeopath or somebody. He is a licensed medical graduate who gives care to individuals irrespective of age, sex and illness, and attends his patients in his consulting room. You may have your clinics or in his homes. You go do a home visit. None of us will do a home visit. You do it. Sometimes you see the patients in a clinic. Sometimes you see the patients in a hospital. So you don't even discriminate the place where you see patients. So your main aim is like to make an early diagnosis, and you will include the integrate the physical, psychological, spiritual and social factors in his considerations about health and illness. So that is where family doctor becomes very, very important. Unfortunately, we are not losing the concept of family medicine, family doctor, because of our own wrongdoings, as Dr. Anaya sir told. If I don't do specialty and if I just get stuck to my MBBS degree, nobody will give me a girl. If I want a girl, I have to do post-graduation. What is a MBBS fellow? What is that? What he knows? That is a concept that we have, unfortunately, sad to say, our senior specialists have inculcated it into the minds of the people. I am the God, the complexity that they had, the earlier people. I am sorry to say this, but we have to introspect sometimes. That godly complex has resulted in what we are today. We are losing the concept of family medicine, which should not happen, and the College of General Practitioners is a right step towards that in establishing the wholesome doctors for the society. Now, he will make an initial decision about every problem which is presented to him as a doctor. He will undertake continuing management of his patients with chronic, current or terminal illness. Prolonged contact means that he can use the repeated opportunities to gather information at a pace appropriate to each patient and build up a relationship of trust which he can use professionally. We know very clearly, when the patient has been referred to us from you people, they trust you more than what they put faith in us, because they are just 5 minutes they have sat with me. I am one super specialist sitting somewhere in Mangalore, putting 500,000 rupees charge. 5 minutes I am giving my time to them. They don't trust me. They trust you people, because you have been with them through their thick and thin. But we are coming just like that. So the trust is with you people. And that is what is most important even for us. I will tell how it is going to be. Now, he will practice in cooperation with the other colleagues, medical and non-medical. He will know how and when to intervene through treatment, prevention and education to promote the health of his patients and their families. Now, I don't tell that, you are capable of giving chemotherapy, but you know when to give. Who requires a chemotherapy, and you are the one who can convince the patient that yes, you take the chemotherapy, you will survive. It's just that I tell that you take chemotherapy, you will survive. They are not going to trust. They are going to trust your word. So he will recognize that he also has a professional responsibility to the community. So he is a doctor of the society rather than a doctor of individual. Now coming to cancer. What is most important is cancer is preventable. 80 to 90% of our cancers that we see in day-to-day practice, not just blood cancer, solid tumors also, are all because of our habits and activities. The de novo cancers which will come because of our fate are only 10 to 20%, or because of genetics is only 10 to 20%. Rest everything is our own wrongdoings. So, and cancer can involve any part of the body, and it is cause of 12% of all deaths in India, and 15 to 20 lakh estimated cancers are there at any point of time, and every year 8 lakh new cases are diagnosed and 5.5 lakh cancer patients die. Now that is a sad part. More than 50 to 60%, more than 60% of patients who are being diagnosed die soon, which should not happen because it's a preventable disease, and still they die. That is because 70 to 80% of cancer cases are detected at late stage, and that is why we are not able to offer a curative options for them. Early detection of cancer helps in complete cure of some cancers, or even in stage 1, stage 2, most of the cancers can be cured. So prevention by taking some precautionary measures is the best way to prevent cancer. But prevention and early diagnosis in the asymptomatic stage, now which allows for curative therapies, are the most effective ways of minimizing the cancer morbidity and mortality. But the discontinuity of care is one of the challenges both patients and clinicians face. There is a discontinuity. What happens, you suspect cancer, you refer to a higher center. After that, you don't know what has happened to the patient. Patient has not come back to you, the referred doctor hasn't called you back, you don't know. And this patient doesn't have trust in the referred doctor, he goes to another doctor, then somebody tells, oh no, why did you go to this doctor, you go to another doctor. So by the time he starts actually his chemotherapy, he would have seen 4 or 5 cancer specialists, and his stage would have been, from stage 2 he would have progressed to stage 4. So this is the sad reality of country. So here I am to explain the role of family doctor in cancer care. There are 8 steps or stages where we can liaise with each other for a better care of the patient. Now, step 1, keeping track of risk factors and determine cancer risk for each patient and conduct necessary periodic reviews. You should be open in your thought process when your regular patient comes to you. You know that he has a smoking habit, he has diabetes, he has obesity. Cancer is not a single causative disease. There are multitudes of reasons which culminate together, to cause cancer. So some patient of yours has more than 1 or 2 risk factors in these. You should be vigilant, and any suspicion you should refer to an higher center, the doctor whom you trust. Now 2/3 of all, why it is most important, 2/3 of all cancers may be prevented by avoiding tobacco, avoiding or limiting alcohol consumption, eating adequate fruits and vegetables daily, knowing family history of cancer, which only you will know, we will never know it. I will give the examples, not cancer, other diseases, but it is the same. Limiting exposure to radiation, like radiation and other things, like for example, people who are living in Nandikur, there is a huge increased incidence of cancer there, which is a known fact. Endosulfan area in northern Kerala, all these children, young, small children developing cancers because of these pesticides. So avoid radiation, avoid that kind of an exposure, and choosing a healthy food, a plant-based diet. We should all have a plant-based diet, not animal-based diet or meat-based diet. 2/3 of our plate should be with the vegetables, whole grains and fruits, and rest everything can be with the lean meat, like fish and chicken. Limit the red meat, that's pork, beef, lamb, deer, buffalo, etc. That has to be limited as far as possible because they are rich in oxidants and they cause a lot of oxidative damage. Now, choose whole grains over refined grains. Maida is a no. It has to be whole wheat atta, preferably ground in your own chosen mill. Rather than Ashirwad Annapurna, You take the wheat, give it to your known mill person, ask him to grind. That is the best part of the wheat powder that you can get. Then, as I told you, processed meat has to be avoided. Whatever is kept packed in the deep freezers of the malls has to be avoided. And alcohol has to be avoided, especially in the context of smoking. Smoking and cancer actually increase the risk of cancer by more than 4 times, not just double, more than 4 times. Regular exercise. Even half an hour exercise per day, it greatly reduces the risk of cancer, because it reduces the obesity, thereby it reduces the oxidative stress on the body and reduces the risk of cancer. So we have to, these are all the simple tips that we can tell to our patients. Simple tips, and that will help the patient in a great way to reduce the risk of cancer. Now, next is early disease screening. Now, whenever you suspect cancer, we should have a screening, some tests, like, we think lung cancer, at least one basic chest x-ray, maybe something problem in his stomach, one ultrasound stomach, something screening tests, prostate cancer suspicion, elderly male having a lot of frequency of micturition, get a prostate specific antigen done, a simple test which will detect cancer in an early stage. So what are all the symptoms that we are looking at? Change in the bowel or bladder or bowel habits, sore throat, unusual bleeding or discharge anywhere in the body, thickening or lump in the breast or anywhere in the body, indigestion and difficulty in swallowing, obvious change in the wart or mole, that's mainly for the skin cancer, nagging cough or hoarseness of the voice, bone pain and recurrent fever, and weight loss. Now, just because the patient has 2 days of these symptoms doesn't mean they have cancer. But if it unusually lasts for long, more than 2 weeks, 3 weeks, the cough is not disappearing, or his weight loss is not disappearing, his anemia is coming again and again, that means there is something problematic in that patient. So we need to refer the patient early. So diagnosis. Step 3 is establishing the diagnosis. Early referral to a necessary end specialty to accurately establish the diagnosis. I'll give an example. 42-year-old lady from Kadaba, the patient is still with me now, referred in view of refractory iron deficiency anemia. They sent to me. I asked the history. It was, most of you may be knowing Dr. C.K. Shastri from Kadaba. He was the one who had referred the patient to me. Now, she gives history of altered bowel habits since 3 to 4 months and history of melena. So there is no question asked. Recurrent iron deficiency anemia, I told you, get admitted, we need endoscopy, colonoscopy first. After that, we will think of whatever it is later. The differential diagnosis for me at this stage is tuberculosis, inflammatory bowel disease, and malignancy. Because, somebody who has a dyspeptic symptoms but having a persistent iron deficiency anemia, it is never acid peptic disease. It is never irritable bowel syndrome. It has to be organic, because the patient has iron deficiency. That means that there is blood loss going on. So, got a colonoscopy that shows an ascending colon malignancy. Now we have sent a biopsy report is said to come. Now this is an early diagnosis, example of an early diagnosis. Next step is staging. How you can help in staging? We need to get necessary imaging and molecular studies to establish the staging and prognosis. Now, this is what we are going to do. That, a cancer patient has come. So, obviously, we are going to ask for investigations for establishing the diagnosis, establishing the stage and the risk category. Whether it's high risk, low risk, all these things. We are going to do the investigation, but all these are expensive. So, same lady. Now, we have suggested her either CECT abdomen, thorax, abdomen and thorax, or MRI abdomen and thorax, or PET CT scan. 3 different imaging options are there for this lady. Now, we have told, but they are totally confused. They don't know what to do. So I know that they are going to go back to Dr. Shastri to get his advice. So what I did, I called him up. I told, sir, if they can afford, if they are reasonably affordable, PET-CT is the best option. It will exactly tell what is the stage. It will not miss a disease gone, that is distant metastasis. So we can get the best of the care. But then it depends on whether she can afford, because PET-CT is anywhere between 13,000 to 22,000 in Mangalore now. So whereas a CECT abdomen and thorax in Venlock can cost maybe 1 to 1,500, maybe abdomen and thorax together maybe 3,000 rupees. So cost constraints. I don't know what is the cost constraint in which shape the family is, but he knows them very well. So I have told him, so if they can afford, PET-CT is the best way to go. I am 100% sure that patient has gone to him today to talk to him. Now I don't know, tomorrow I will know what is their further decision. But this is how we can, collaborate. Without that it is not possible. I ask for some investigation. What happens if the patient doesn't have a family doctor? He will go to another oncologist, and that oncologist will tell something else. This patient will get confused totally. Rather they have a family doctor, then family doctor becomes a center person, and both the oncologist and the patient will center around him and get the best of the care. Next is treatment. Now, some of you may prefer to give chemotherapies. Some of the simple chemotherapies. I'll give you the examples. Under our supervision, they will all be involved in counseling patients and their families, providing family support. Time to time, we need to tell them, yes, this is going on, they are in this stage, this, okay, they have to get this kind of a treatment. All those things, we all should be involved. Now, this is another recent case. 70-year-old gentleman from Mudbidri was referred to me by the GP from there because of a pancytopenia. I admitted him, did the blood tests. It was acute leukemia, acute myeloid leukemia. Now I started him on drugs called azacitidine and venetoclax. They are the newer chemotherapy drugs that are designed for elderly people. The regular chemotherapy, he would have died. Now this is designed only for the elderly people. They tolerate it well, and it is very effective in controlling the disease. I am not telling that it is going to cure the disease, but it will control the disease. Patient will get some 6 months, 1 year or 2 years of healthy life. Now, the first 2 cycles were given in KMC because I had to admit he was sick and all. I had to admit each cycle costed 2.5 to 3.5 lakhs. It is a bomb. How many of patients can afford this kind of treatment? So what now I did, I have told him, you come to my clinic once a month. Do basic investigation, show me. If it is fine, I'll give you chemotherapy prescription. You get the drugs directly from the company or from a distributor, where you get at least anywhere between 40 to 80% discount on the MRP, and you go back to your GP at Mudbidri. I will call him and I will tell him that you give the chemo, because they are simple chemos. They are not going to cause any problem. You can give it in your clinic. It's a half an hour simple drip. You take it there. Now it costs 50,000 rupees per month. Because the drug cost is reduced. He doesn't have to get admitted in one of the sophisticated wards of KMC. He is not even getting admitted in Mudbidri also. From his house, evening he goes, half an hour drip he takes from his GP, comes back home. That's it. With the IV line intact there. That's it. For 5 days, every month. This is what we can establish. They are very happy. The patient and patient relatives are very happy because the cost has come down, and now 4 months of treatment is over and he is doing well. The quality of life is good. He is doing well. That is what is required. ultimately, if I tell that, all the 6 cycles of the chemotherapy, or here it may go on to 12 cycles or even 24 months of therapy, if I tell that, I am selfish, I have to give all those things to me, myself, to the patient, then at the end of 6th month, he will sell his home. And after 6 months, no patient will come back to me. Because I am so expensive, nobody can afford me. And not just that, they will go back and curse that family doctor also. What kind of doctor you have sent? That fellow has screwed our home, we have lost our home, we have lost our patient also, everything we have lost. So the family doctor also becomes a villain. I also become a villain. It doesn't make any sense. So you are also should be happy, I also should be happy, every one of us should be happy. That is ultimately the goal. So that is where we can have the shared responsibilities. Now, step 6 is shared care. Share the monitoring of the treatment progress and side effects. This comprises patient and family support throughout the disease course. I'll give the same person's example. Same person, in between the cycles, twice he developed fever. Promptly he went to the family doctor. The family doctor promptly called me. So I told, you get some basic tests there, sir, and you give this particular antibiotics. He gave there, patient improved without direct consultation with me. Both the times he did not come back to Mangalore. He stayed in Mudabidri, the story was over. So that is like, patient is also happy. Now, for every drop of the hat, I don't have to run to Mangalore. That confidence they get. Now, the 7th step is advanced illness management. This is like, patient cannot be cured. Now, somebody who cannot be cured, if I keep the patient in one of the deluxe rooms in KMC and tell that I will give morphine infusion to this patient, probably I will be the worst person on this earth. It doesn't make any sense. He is going to die. So I don't have to admit. I should not be admitting him. A lot of the times we still admit because of lot of political reasons and other things. But then, humanitarian basis, we should not admit them. So here the most important thing is quality of life. We have to maintain the quality of life of the patient. That's the only aim. So again, that can be done very easily. Now, this is a 90-year-old gentleman, well known. This person, all of you know him. I will not name him because I don't have the right to do that. But this patient you all know, not as a patient, as a person, as a celebrity, So he was referred to me for high WBC counts. Okay. I admitted him for 2 days, evaluated. He was found to have chronic lymphocytic leukemia, and also he had a liver lesion. We did alpha fetoprotein, which was more than 700, proving that he also has a hepatocellular carcinoma. Now, a 90-year-old person who, he is right now, he is doing all his activities independently. Just he had some sore throat and fever. That's why he went to his local family doctor. He did some basic tests and found that counts are high and referred. Just because he has come to me, if I go and give chemotherapy to this person, it doesn't make any sense. So I told, and family also can't afford also. I counsel the family members, what do you want? You want treatment, treatments are there. It's not like, treatment is not there. The question is whether you want to really give the chemotherapy, you want to really give those side effects and screw up his quality of life, or you allow him to live peacefully with his quality of life maintained without any major treatment. They opted for a palliative care. So I called up the doctor there. I told, boss, something happens in the middle of the night also, don't worry. He is not a candidate to be intubated and put on ventilator in a tertiary care center. If he is going, let him go peacefully. So we don't know God, God has given how much life to him, I don't know. But how much ever life he has, let him be there. You call me anytime if you have any problem managing him. I will tell you what to do. He doesn't have to come all the way from Udbidri to here just to see me, because for every cold fever, just because he has got a malignancy. You just tell me. And I told them, your family doctor is the best person to handle this. He will take care of you. You don't worry. There is nothing much we can do. Tomorrow something breathing difficulty happens. He develops a severe chest pain. We are not going to do anything. Your family doctor also will not give him anything except for some pain relief and some minor treatment. That's the same thing I am also going to give him if you bring him here. So have faith in your local doctor and keep him there. And now last 6 months he is there. He is still alive, doing well, by God's grace. Periodically the doctor calls me for some minor problems. Otherwise he is doing well. Another patient, 65-year-old lady, progressive myelodysplastic syndrome. She was terminally ill. Now she was there under the care of the local family doctor for around 3 months. Period to period, the relatives used to come to me, take a prescription for morphine. They used to collect the morphine tablets from at our KMC, and they used to go back. That's it. In the last 3 months, I didn't see her even a single time. And she finally succumbed to her illness at home. And declaration of death and further formalities were all facilitated by the local doctor there. The family was also happy. They finally thanked me for all this one and all. And they were gracious to the local doctor also there. So this is how harmoniously we can manage even end of life care also. We don't have to worry. When it comes to end of life care, a lot of the time what happens is that you have the fear. If he dies in my clinic, what to do? The patient's relatives may get agitated. But as far as I am concerned, if the patient is on a palliative care, I will properly counsel them so that they will never get agitated. I'll tell that this is the best you can get, and this is the best you can give to your relative. Be happy with that, and you can comfortably, in the sense that the local doctor can comfortably take care of the patient in his last days. That is what we need to do. The step 8, or the last step, is follow-up or monitoring. Continued follow-up of patients once they are considered cured. For the recurrence of the disease or some other illness, second primary disease, they can be monitored. Another example, 35-year-old lady referred to me from Ballari. Acute myeloid leukemia. We treated her with chemo in 2014 with Vajpayee scheme there that time. And she got cured in 2015 completely. Since then, she is follow up with her family doctor regularly there in Ballari. Once a year she comes to me. That's it. For whatever else, she goes to the doctor there. If he has any doubts, he gives me a call. She doesn't come running to me for every minor problems. So this is how, now it is 2015 to 7 years. 7 years of continued care with, she has got the best of the care from her local doctor. So another example, this is not malignancy. 67-year-old lady referred to me from Dr. Prasad Shetty from Hosmar for pancytopenia in September 2021. Bone marrow was suggestive of severe aplastic anemia. Now, standard of care for this lady is anti-thymocyte globulin with cyclosporine treatment. That is upfront around 6 to 7 lakhs for the first 1 month, followed by 25,000 per month for 1 year. This is the cost that we are looking at for ATG therapy. Now, ATG is not something I can do it in Colasso or SCS Hospital General Ward. It has to be in a private proper room. It is a proper acute leukemia chemotherapy like treatment. So they couldn't afford, obviously. So I spoke to Dr. Prasad Shetty. I told, I will give her certain medications. You give it to her. I will prescribe her. You give it to her there. We will try to manage. So we gave her danazol, cyclosporine, eltrombopag and romiplostim. Eltrombopag and romiplostim are the thrombopoietin analogs which try to increase the platelet count. Now, with this treatment, the cost of therapy still was high. So I'm not telling it was low, but it costed them around 40,000 per month for 8 months. And by August 2022, she was on a minimum medication, that is 1 dose of cyclosporine per day. That's it. She is in complete remission. At 67-year-old lady, when we give ATG, anti-thymocyte globulin, generally we tell 50% risk of death during the treatment. And this lady is now completely cured of her illness without even giving ATG. And 1/4 of the cost what is actually would have incurred to them. In between, there are 2 episodes of fever which were promptly managed by Dr. Prasad sir by telephonic consultation with me. It is not aplastic anemia is not a malignancy, but then any disease for that matter we can lyse very easily. Another patient, 50-year-old gentleman from Puttur, referred to me by physician in 2018. Anemia, workup showed myelodysplastic syndrome. Treated initially with lenalidomide and with partial response. Progressed to acute leukemia in 2019. He was treated with decitabine chemotherapy because he was not very fit for the intensive chemotherapy. For 3 months, he developed lung aspergillosis. He was given amphotericin B. He is a well-to-do family, very rich man. I referred him to Narayana Hrudayalaya, Bangalore, for a bone marrow transplantation. They got counseled there also for a transplant. But after that, unfortunately, lost to follow because he didn't have any family doctor. There was no local doctor there helping him. He just was lost to follow. He went to homeopathic medicines, And again, he presented to me in March 2021 with MDS and acute leukemia transformation again. Now, this time I told him, boss, you have to go for a transplant. Otherwise, you are not going to live. Now, he underwent a bone marrow transplant in May 2021. All his treatments were stopped by May 2022. This May, I stopped all his medications, everything. Now, he is on vaccination. Like, once we do a bone marrow transplantation, their blood becomes like a neonatal blood. So we have to, restart the same IAP vaccination schedule. We need to restart again for this patient. So he is taking it in Government Venlock Hospital now. He is comfortable, doing well. But if the person doesn't have a family doctor who understands the concepts of acute leukemia transplant, this is going to happen. Luckily, he survived. But there are so many people who lost their life because there is no family doctor. They invariably go to Ayurveda, homeopathy, Nati Aushadhi, all these things. And, ultimately, they don't know what exactly they are supposed to do. This is again, lack of family physician, family doctor, I will tell you. This is not a cancer. 43-year-old lady came for rituximab therapy for chronic ITP since 2013. Since 2013, she is a patient of chronic ITP, not with me, with some physician. She has long-term history of ecchymotic patches and she had postpartum hemorrhage before the onset of chronic ITP. Twice she had postpartum hemorrhage. She was given steroids, azathioprine, dapsone, methotrexate, cyclosporine, and intermittent pulse methylprednisolone at 30 milligram per kg per day for 2 to 3 days like that. And she was given all sorts of medicines. Developed partial hearing loss, hypertension, and impaired glucose tolerance. Everything was blamed on steroid also. So this lady came to me basically because her cousin I treated for chronic ITP with rituximab and she got cured. So she got a hope, okay, I will also get cured. So she came to me. So she came to me, so I told, okay, chalo, this is the cost of rituximab, 4 doses, so altogether around 60 to 80,000 rupees for 4 weeks. She told, I have a brother who has low platelets, I have a daughter who has low platelets. That is like, 60 to 80,000 per person for 3 members in the family, I can't afford, doctor. And she told, then I told, madam, you don't have ITP, and I took back that rituximab explanation sheet. I took it back. I told, you don't have chronic ITP. This is not chronic ITP. You have so many family members there. Then she tells, her father had low platelet count and he had succumbed to an intracranial bleed several years ago. This lady was toxic with all kinds of medications for the so-called ITP, but she actually did not have ITP. Then I told her, you have to go to Bangalore, because right now there is no facility. At that time, I didn't have any facility to investigate this. You have to go to Bangalore. One special lab is there. You go there and get yourself investigated. With lot of dilly-dallying, finally she agreed, and she was fed up of taking Vislone, so she finally went. There, peripheral smear, so many peripheral smears were done in Mangalore, but unfortunately everybody missed this. She had giant platelets. Now you can see there is a platelet which is almost as big as red blood cell there. And there is another, this red mark is there. This is something called Dole body that is present in the neutrophils. It's an inclusion body. So he then approached another lab, and on compassionate basis we got a genetic test done free of cost. There is something called MYH9 gene mutation, or it is called May-Hagelin anomaly, one of the rarest congenital thrombocytopenia syndromes. To be frank with you, this was the first case I was seeing in my entire life. I had not seen this. So I wouldn't have made a May-Hagelin anomaly diagnosis except for her family history. If she hadn't told any of the family history, I would have gone and given rituximab to her. And she might have died also because of opportunistic infections. But the family history. Now this family history will be known only by the family doctor. Because family doctor is the one who treats father, mother, son, everybody. We don't treat the entire family members. We don't know who are the family members also. We know only the person who is sitting in front of me as a patient. Other than that, we don't know anything. So if she had a family doctor, this entire 8 years of unnecessary treatment could have been avoided. A good clinical history taking, the people would have thought, they might not have made a May-Hagelin anomaly diagnosis, but they would have told, yes, it is a congenital bleeding disorder. So congenital bleeding disorder, what are you going to do? You don't do anything. If she bleeds, give platelets. That's it. Finished. Story is over. You can't do anything. There is no cure for this. It's a congenital disease. So we could have avoided all those problems. Now, this is a similar case. 17-year-old boy. This patient had gone to Dr. Rajesh Krishna, who is the other hematologist in Yenapaya Hospital. He had thrombocytopenia. Initially given a course of steroids, it didn't work out. The parents were unhappy. So somebody told my name, so they came to me. So now I told, this doesn't look like ITP to me, because there is no response to steroids. We will have to do a genetic test, which costs around 16,000 rupees to see what exactly we are dealing with. The parents were really unhappy. Again, I am telling 16,000 rupees. This one. They thought I will give another drug, and I would have sent. Then I told, okay, chalo, okay. I will ask you, do you have low platelets? I asked mother. No, she told. How do you know? I am a rheumatoid arthritis patient of Dr. Sajjan Shanai. Once in 3 months he checks my blood counts. It's always more than 2 lakhs. Then I looked at father. I asked him, what is your platelet count? I don't know. He is a 54-year-old person. I told him, we will do one thing. We will check your blood. If you have low platelets, we will do genetic test. If your platelet count is normal, I will give you medicines. This is a deal we got. I told you, give the blood test here only, 20 minutes we will get. He gave the blood test. For a shock of his life, his platelet counts were only 45,000. 54-year-old gentleman never knew that he had a thrombocytopenia. Now I told boss, you have given to your son. Now you better do the genetic testing, because your son may give it to your grandson. So this is what we need to now establish. So we got the genetic test done, and he also had the same disease of May-Hagelin anomaly. And now with this genetic report, now they are convinced that they don't require a treatment. The treatment is required only when there is active clinical bleed, and that treatment is nothing but platelet transfusion, nothing else. So the lack of family doctor, causes trouble. So now I was telling you, if doctor in the family, can he be a family doctor? This is what we will see. Do you agree with me? I told that, a doctor in the family is not a family doctor. Do you agree? Yes. I will give you 2 examples why it is so. Any doctor in the family cannot be called. I'm talking about only MBBS doctors. I'm not talking about Ayurveda doctor or homeopathy doctors and all. Even a MBBS or even a cardiac surgeon in the family cannot be called as a family doctor. I will tell you exactly why. A 66-year-old gentleman presented with MDS RAEB, that is myelodysplastic syndrome, that is progressing to acute leukemia. And he within 15-20 days he progressed to acute leukemia. So he had a molecular mutation called FLT3-ITD. There is one mutation that was positive. Now why I got it done is there is a targeted therapy for that. So I gave him azacitidine, that is a drug that I told that time, with another drug called midostaurin. Now that, not azacitidine, decitabine with midostaurin. This is a targeted therapy for this particular mutation. So I started treatment. They told, we have doctors in our family, so we will take the treatment at local place. So first month I treated in Mangalore. After that I also got convinced, okay, fine, no problem. You can take the treatment in local hospital. But any problem has to be coming to me. Because the person who referred to me, this patient, the doctor, these people are not going back to him. They are going back to their relatives who are senior surgeons in their native. They are going back there. I told any small problem, it has to be brought to my notice. They told, okay, and all, they went. Now, 6 cycles I gave chemotherapy. He didn't recover very well. He was still having a lot of cytopenias, requiring recurrent transfusions and all. Bone marrow I did, it was hypoplastic. I was not sure what was happening, but I did the bone marrow, repeat bone marrow, and within 15 days he came back to me with a necrotizing fasciitis of the left thigh. He was taking himself insulin injections there. Okay. Now it was treated there. It was managed improperly by a surgeon. Why I put it as improperly by a surgeon is, he knew how to treat a necrotizing fasciitis of the thigh as a surgeon. But this patient has neutrophil count less than 500. He is a neutropenic patient, so he did not know what antibiotic to give. The day one, this patient for a necrotizing fasciitis requires a combination of meropenem with the teicoplanin with the voriconazole. This is the minimum drugs that we have to give on day one before even we draw the culture also. Sometimes, sometimes culture facility, blood culture facility is not there, no problem. You push the antibiotic because he doesn't have neutrophils to fight. But this patient came 5 days after the onset of the illness. And finally he succumbed. I couldn't manage because by the time he came to me, he was in a florid sepsis. One single call, if they would have told me that, necrotizing fasciitis is happening, I would have told you, give meropenem, give teicoplanin there, then you send him to me. This is why I told you. He was a senior surgeon. He is a very reputed surgeon. There is no doubt about it. But he does not know the concept of cancer care. Now, you can ask me, do we know the concept of cancer care? No, but you don't hesitate to call us. When you don't know something, you don't hesitate to call us. You immediately pick up the phone and tell, Dr. Prashant, this is happening. Your patient has come. This is a problem. What we should do? That is what is required. That is what cannot happen with the family doctor because they are emotionally attached. The doctors in the family are emotionally attached. They cannot take the rational decisions. They should not be treating. If my father gets some illness tomorrow, I should not be treating. If I treat, there is a high chance that I will mismanage it and he may succumb to that. So I should just stay away from that. Except for giving reassurances and making sure that he is taking tablets, I should not venture into anything else. Another case, this is the last case I'm going to talk. 80-year-old lady presented with acute myeloid leukemia with high counts. She also had this FLT3-ITD positivity. So I gave her azacitidine 5 days per month with midostaurin 25 mg per day You know, this lady really did well. You know, after 6 cycles, bone marrow still has some blasts, 16% blasts are there, but 80-year-old lady, now 6 months down the line, after the diagnosis of acute myeloid leukemia, she comes walking to my chamber and she is able to tolerate a bone marrow test. Remember, that is like, you know, she is such a good, healthy lady. Now, unfortunately, I told them to go elsewhere. I told, I am putting a full stop to your treatment. I cannot treat your mother because she had 2 sons. One is a district surgeon in one of the district hospitals in Karnataka. Other person was a community medicine professor. They were treating her. So all that I used to get as an information about the patient was that at the end, beginning of each cycle, one CBC report used to come to my WhatsApp. Doctor, shall we start the next cycle? That's all. I don't know whether the patient developed in between fever. I don't know what happened to the patient. How is she doing? Nothing. I told, this is not the way to go. At least once a month I need to see the patient. To see whether, you know, I am going and giving toxic medicines. They are simple chemotherapies. But still, in a septic patient, this can kill the patient. I don't know whether patient is having infection or not. And I am just relying on your words and I am giving treatment. I cannot do this. They told, no, doctor, you have to treat, and they just pesterized me. Then I told them, you give me, you know, so far I don't have the habit of taking consents for chemotherapies. I don't generally take it except for KMC patients. There is a consent form is there. We fill it. But in my clinic, I don't take any consents. I just rely on the word-to-word conversation. So I told for the first time, please you give it in writing that you are going to give the treatment, you are going to monitor it. If something happens to her tomorrow, you will not blame me, you will take the blame on yourself. You give it in writing. I will treat her. Over the phone only. Over the WhatsApp I will treat. I don't want money. It's not about money because they were transferring money to me. WhatsApp, Google Pay. So it's not about money. It's about tomorrow our reputation. It is about, you know, our conscience. If something happens to her and if she under my care, in the sense that, you know, I've never seen her but she succumbs, I can't forget it in my life. That, you know, because I didn't give proper care, that's why she died. And there is a chance that they will go for a litigation. You should have told us to bring the patient, we would have brought. This is what they will tell. What defense I have? So I told, you are not family doctors. You cannot come out of emotions. If you give me high risk consent form in the midway of the treatment, I will continue to treat. Otherwise, I am not going to treat, I told. After that, they have not contacted me. They were not ready to give me consent. They wanted me to treat like that without consent. I asked them, you are doctors, you know the value of informed consent. So I am asking you, you give informed consent. What is wrong in that? They were not ready. So I told, enough is enough, I am not treating. Because sometimes we have to take care of ourselves also. You know, it is not just the patient, you know. We are not here to take care of only one patient in our entire lifetime. We have to cater to the society. So we have to take some tough decisions. So this, why I brought up this is, a doctor in the family is not a family doctor. A family doctor is a person who can rationally think irrespective of age, sex or the disease, and, you know, who is ready to sacrifice his day and night for the welfare of the patients. So with that, I conclude my talk with summarizing that role of a family doctor in maintaining the health of the society as a whole is tremendous. You know, you maintain the health of the society, not just an individual. And no society can survive without family doctors. A good liaison between a family doctor and treating specialist is cornerstone in treating any patient, not just cancer patients. And with the good utilization of family doctor, the private healthcare sector can reduce the litigations by a large extent. This is my personal belief. With that note, I conclude my talk. Thank you. IMA College of General Practitioners. Annaya sir, you need please accept our felicitation.
Prevention and its management. Usually after every CI case, the doctors will ask any questions or any questions and answers, something like that. Then today actually there are no questions at all, because they used to say that when we ask for when there are no questions, either they didn't understand anything or they fully understood. So we can proudly say that everyone has fully understood, and I could make out everyone listening and very mesmerized by his talk. And I can proudly say that this is one of the best talk in our CNC. I thank Dr. Prashant very much from all our members for all this. Then secondly, I thank our President Dr. Abbakka for conducting this meeting. Thirdly, I thank every one of you for coming in large numbers and making this program a very successful one. And we are very lucky to have a good talk by Dr. Asn today. And now I thank our today's sponsor, Dr. Usman Basha. Thank you very much. And thank the media persons also, Mr. Sandeep and Shashira also for covering this program. Thank you. Sandeep, please come. Come. Our office boys, Mr. Sushant and Arjun, for helping us to conduct this program. Lastly, thank Mr. Abbakka, the manager of Maya International, for arranging our today's hall and good menu and for conducting this program. Thank you one and all. Thank the right